Right, today we are going to talk about trigeminal neuralgia, right? What is trigeminal neuralgia? You know, trigeminal nerve is the largest cranial nerve or fifth cranial nerve, which basically has 3 divisions, as I discussed in the previous lecture, and the basic concept related with the trigeminal nerve, that it has basically 3 divisions: ophthalmic division, which is supplying upper part of the face, then there is maxillary division, which is supplying the middle part of the face, and then there is mandibular division, which supplies the lower part of the face. We give the sensory supply to different parts of the face. Now, what is trigeminal neuralgia? Neuralgia stands for neuropathic pain. Neuralgia stands for neuropathic pain, and trigeminal means fifth cranial nerve. So it means trigeminal neuralgia is basically neuropathic pain in the distribution of trigeminal nerve, right? Trigeminal neuralgia is basically a neuropathic pain, right, in the distribution of one or more branches of trigeminal nerve. Or we can say trigeminal neuralgia is a syndrome. Trigeminal neuralgia is a syndrome characterized by sudden, severe paroxysms of sudden and severe paroxysms of neuropathic pain. What is it? Trigeminal neuralgia is characterized by, right, sudden and severe paroxysmal pain, episodic pain, in the distribution of one or more branches of trigeminal nerve. One or more branches of trigeminal nerve. Let me repeat it. What is trigeminal neuralgia? It's a syndrome characterized by a sudden, severe, paroxysmal, neuropathic pain in the area of distribution of one or more branches of trigeminal nerve. Is that right? Yes. But this reminds me to tell you, rather to ask you, what are the other neuropathic pain related with head and neck, right? You can say neuropathic pains in head and neck. Of course, I will tell you one cause, and you have to tell me some other causes. One cause, and the most common cause, is trigeminal neuralgia. Can you tell me some other cause of neuropathic pain in the face?
Glossopharyngeal.
Wow, very good. Glossopharyngeal neuralgia, 9th cranial nerve, right? Then there is, what will happen? In glossopharyngeal neuralgia, again there will be neuropathic pain, which will be sudden and severe, episodic, and in the area supplied by the 9th cranial nerve, like posterior 1/3 of the tongue, tonsillar areas, or from the ear, right? Then, can you tell me one more cause of neuropathic pain? Post-herpetic, very good. Post-herpetic neuralgia, right? It may involve any unilateral dermatome in the body, but in the head and neck, most commonly it involves the ophthalmic division, right? Post-herpetic neuralgia. So you have told me 3 neuralgias which are related with the facial pain, neuropathic facial pain. Neuropathic facial pain can occur with trigeminal neuralgia, it can occur with glossopharyngeal neuralgia, it can occur with post-herpetic neuralgia, and very good student will tell one more cause, that is geniculate neuralgia. Very good. Geniculate neuralgia. This is from geniculate ganglion in the 7th cranial nerve, right? It is characterized by the facial nerve paralysis and also severe pain in the ear, right? But today's our lecture is related with trigeminal neuralgia. But before really I go into detail of trigeminal neuralgia, I want to make 2 things clear. Number 1, the facial pain. The most common cause of facial pain is not neuropathic pains. The most common cause of facial pain is originating from the teeth or from the temporomandibular joint. The most common cause of facial pain is originating from the teeth or from the temporomandibular joint. Is that right?
Yes.
Neurologic causes of facial pain, even though they are important and they produce very severe pain, but thank God they are less common. They are less common. Before really I go further, I think we should elaborate what is neuropathic pain. What is neuropathic pain? Yes. What is neuropathic pain? It's a kind of pain, yes, neuropathic pain, which results from the damage or disease of somatosensory nerve fibers. Don't tell anyone that neuropathic pain is which result from the damage to the motor nerves. Of course, motor nerves don't cause pain. If motor fibers are damaged, there will be muscle weakness. Or motor fiber to the glands is there, then there will be failure in secretion of the glands. But what is neuropathic pain? Neuropathic pain is a pain which results from disease or damage to the somatosensory nerve fibers. Is that right? Now, let's go back in detail of trigeminal neuralgia. Okay? Now, we can discuss the clinical manifestation of trigeminal neuralgia with the help of a philosopher. Maybe you know there was a great philosopher, Socrates. There was a great philosopher, Socrates. Let's take the help of the Socrates, right? And we talk to the Socrates, and Socrates will tell us what are the classical clinical presentation or manifestations of trigeminal neuralgia. Let's write it here with respect, of course, with utmost respect. Socrates. Right? Now, Socrates, right? First of all, we'll start about S. It's a mnemonic basically, right? Socrates. Now, S stands for the site of the pain. Site of the pain. O stands for the onset of the pain. C stands for the characteristics of the pain. R stands for the radiation of the pain. A stands for the associated symptoms with the pain. T stands for time and temporal relationship of the pain. E stands for exacerbating and relieving factor for the pain. And S stands for, yes, severity of the pain. Right? So let's start with trigeminal neuralgia and Socrates. Now we are going to discuss about trigeminal neuralgia, clinical manifestations, and our great Socrates. So first of all, S. What is the site of the pain? Again, you know that this pain is usually it is unilateral. And what is the site? Facial. It is unilateral facial pain. Classically, this is unilateral facial pain. Remember, if trigeminal neuralgia occurs bilateral and in younger patients, think of a disease called multiple sclerosis. Right? But in classical cases, in typical cases, trigeminal neuralgia is a unilateral facial pain, right? Which most commonly occurs in which division of trigeminal nerve? Let me draw a diagram. Right. So, yes. Here is ophthalmic division and maxillary division and mandibular division. So, number one, mandibular division is also called V3,
Yes.
right? Maxillary division is called V2 and ophthalmic division is called V1. Is that right?
Yes.
Now, here what you really want to learn that this unilateral facial pain most commonly occur in the distribution of V3 in mandibular area. Most commonly this pain is in this area. Less commonly, now V3 cases with severe pain in mandibular area or mandibular division are more than the cases in V2
Yes.
or combined V2 and V3.
Yes.
Is that right? And cases in V2 are less common with cases with pain in V1. What does it mean? That most commonly, trigeminal neuralgia, patient complains of the pain in distribution of mandibular branch, right? Less commonly in maxillary branch or mandibular and maxillary branch, both may be involved. And least commonly, this neuropathic pain may occur in ophthalmic division. And very rarely, it may occur in all three divisions. Again, what did we say? That this is a sudden, severe, episodic neuropathic pain, which comes in paroxysms, comes into attacks, and this pain is in one or more divisions of trigeminal nerve. And a good doctor should know, most commonly it is in mandibular division, less commonly in maxillary division, least commonly in ophthalmic division, and of course V3 and V2 in combination can also occur, and very rarely V3, V2 and V1, all of them occur, right? All three divisions. But again, it's worth mentioning that if a patient comes, a younger patient, and he has trigeminal neuralgia on both sides of the face, think of multiple sclerosis. Think of multiple sclerosis, right? Now come back. So it's unilateral facial pain, more in the mandibular division, less in mandibular and maxillary division, or in the maxillary division only, and least commonly in ophthalmic division. And I must mention, but if there, what is the most common cause of neuropathy in ophthalmic division? Now I'm rephrasing a question. Most common cause of neuropathic pain in mandibular division is trigeminal neuralgia. Yes. Most common cause of neuropathic pain in mandibular division is trigeminal neuralgia. What is the most common cause of neuropathic pain in ophthalmic division? Post-herpetic neuralgia. Very good. Post-herpetic neuralgia. Am I clear? Okay. Let's go with this. So we were talking about this pain, and of course this pain, not only we can say this occurs in these divisions, we can also say that this pain is originating, or it may be present in the gums. Of course, gums are supplied by trigeminal nerve, lower gums are supplied by mandibular branch, and upper gums are supplied by maxillary branch. So pain may, we can also say that patient may phrase that patient feels severe pain in gums, or in lips, or cheek, or in the chin, right? So this is all about site of the pain. So we can say the site of the pain can be, yes, gums, yes, gum, cheek, lips, and chin, right? Then we come to the onset of the pain. What is the onset of the pain? Yes, this is very important. The characteristic pain comes suddenly, like lightning bolt. Sudden pain. It's not one of those pains we start gradually and then they build up. No. It's a very sudden pain. It's like electric shock like pain. So we can say that onset of pain is like a paroxysmal attack. Right? Pain is sudden onset. Sudden onset. Or we can say it comes as attacks. Sudden attack. Sudden attacks we can say paroxysm. Right? So this pain is basically onset is sudden. And characteristic of pain. Yeah, this is very important to ask the patient. Right? That what are the characteristics of the pain? What is the quality of the pain? How the patient feels. That how the pain feels. In this specific case, in trigeminal neuralgia, patient says pain may be like electric shock like. That someone has given like electric shock, lightning bolt, right? So this can be pain characteristic may be electric shock like. Or patient may be like lancinating pain, electric shock like pain or lancinating pain. What is lancinating pain? Like cutting pain. Someone has cut with a knife, very rapidly ripped. So it may be lancinating pain, cutting pain, stabbing pain, right? Of course, it is not dull pain. It's not burning pain. Burning pain is a characteristic of, yes, post-herpetic pain. Dull and deep pain is usually maybe migraine or some other right? But this pain is not dull. It is not deep. It is superficial pain, but cutting pain, stab-like pain, stabbing, someone put a piercing pain, right? So, what is this pain? Socrates is helping us. This is unilateral facial pain, felt more commonly in mandibular area, less commonly in maxillary area, or mandibular and maxillary combined, and least commonly in ophthalmic branch, right? This pain appears as sudden and severe paroxysms, episodes, and patient feels like as if it is that part of the face is stricken by the electric bolt, or like electric shock, or lancinating, cutting, stabbing, severe pain, right? And sometimes pain is so severe, that patient winces with it. Right? Winces means the spasm of facial muscles. Very severe pain, and patient winces. So we can say this pain may be associated, yes, this pain may be associated with spasticity in the face, right? Spastic contraction of facial muscles. We say that patient may wince. Patient winces, right? And due to that reason, it is also called, this pain is called tic douloureus. Tic douloureus. Tic douloureus stands for, a tic is involuntary movement, douloureus pain. So with pain there is involuntary movement of facial muscles. And of course, another way some patient may explain this pain as if it radiates from the angle of the mouth. Again, mostly it is unilateral, right? So some patient may feel that pain radiates from the angle of mouth. Right? It may radiate to the ear, or it may radiate to the eye, or it may radiate to the nostril. If it is radiating to the ear, you think of mandibular division. If it is radiating from the angle of the mouth, it radiates towards the eye, think of ophthalmic division. If it radiates towards the nostril, think of, we are wrong. From the angle of the mouth, if it radiates to the ear, it is mandibular division. If it radiates towards the eye, this is maxillary division. Maxillary division, you know. Mandibular division, and here it is maxillary division. And to the nostril, this is ophthalmic division. Is that right? So another way that when we talk about radiation, that from the angle of mouth, it may radiate to, now you will tell me, right? From the angle of mouth. Yes, from angle of mouth, if it is radiating to the ear, mandibular division, or if it is radiating to the eye, maxillary division. If it is radiating to the nostril, it is ophthalmic division, right? And this pain is associated sometimes due to its very severe nature. The patient, there is facial muscle spasm, and that is called, the patient winces, and called tic douloureus. Here I want to tell you something very important. This pain should not be associated with other phenomenon. For example, this pain should not have associated sensory loss on the face. This pain should not have associated sensory loss in the face. Right? If there is sensory loss in the face, or this pain is associated with 7th nerve palsy, or this pain is associated with 8th nerve, the doctor should get worried. More dangerous underlying causes are there. More dangerous underlying causes are there. Let me explain why. What is the real underlying cause? But before I go for cause, why don't I tell you the timing and other features, right? So, timing. As I told you before telling the timing, it is sudden, severe, episodic pain, electric shock like cutting, right? And it may radiate from angle of mouth to the ear, or to the eye, or to the nostril, and sometimes pain is so severe that patient winces. The only good thing about this pain is, thank God it is very brief. It lasts from few seconds, at the most 1 to 2 minutes. Classically, this pain lasts from few seconds to 1 to 2 minutes, not more than that. And some very lucky patient may have even a pain for split of a second. That is why they say they got a pain like electric shock like pain. Right? So these are paroxysms of severe, excruciating, electric shock like stabbing, lancinating, piercing, cutting pain in the area of distribution of one or more of the trigeminal nerve, and this pain lasts only for few seconds, at the max 1 to 2 minutes. If trigeminal pain like that lasts for longer time, you have to review your diagnosis. Right? You have to review for the diagnosis. Then E stands for exacerbating factors. I will mention here triggering factor, right? I will go into this. What triggers the pain? In some patients, pain may be triggered spontaneously. Pain may be triggered spontaneously. But in some other patient, the neurons become hyperexcitable in such a way that certain movement or certain tactile stimuli may precipitate the attack. Right? In these patients, sometimes non-painful stimuli precipitate the attack of the pain. Non-painful stimuli. For example, you touch your lady very softly here and she get a very severe attack. And that is neuropathic pain if she is suffering from this problem. Now a very little touch is normally not painful. Is that right? So it means sometimes non-painful, such stimuli which are usually not painful may precipitate such a severe pain. And when such stimuli which are not painful but precipitate these stimuli, severe neuropathic pain, or precipitate the pain of trigeminal neuralgia, we say there is a phenomenon called allodynia. What is that called? Allodynia. So what is allodynia? Allodynia is one of the characteristics of neuropathic pain. Because in neuropathic pain, some neuronal fibers are hyperexcitable. And sometimes non-painful stimuli are also called non-nociceptive stimuli. Non-nociceptive stimuli may precipitate severe pain. Is that right? We say there is allodynia. Now allodynia may be movement allodynia. Movement allodynia. It means some movement in this region may precipitate this pain. For example, a very unfortunate person, a simple smiling may precipitate pain. Simple smiling. Because when you smile, right, muscles move and some sensations are generated, and these muscle proprioception may precipitate the pain. Later on pathophysiology I will tell you how simple proprioceptive or tactile stimuli can precipitate attack of trigeminal neuralgia. Or smiling or eating, I mean especially chewing, even swallowing may precipitate trigeminal neuralgia. This reduces their quality of life. Simple talking can precipitate trigeminal neuralgic pain. So sometimes these patients are very afraid even to smile. Sometimes they avoid eating, and that reduces the, what is this? Weight, produces other complications. Even sometimes they'll keep on listening and they don't want to answer talking. In some patients, talking may precipitate the pain. Remember, glossopharyngeal neuralgia can also be precipitated by swallowing, because glossopharyngeal nerve supplies posterior 1/3 of the tongue and tonsillar area. So swallowing, that area is of course involved. Anyway, so this is movement allodynia. And then sometimes a simple tactile stimulation may trigger severe attack of pain. Right? That is called tactile allodynia. Tactile allodynia. Tactile allodynia, in this case, even in patient's face or lips or gums or tongue, because anterior 2/3 of the tongue is supplied by mandibular division, posterior 1/3 of the tongue is supplied by the glossopharyngeal nerve. Now, in tactile allodynia, what happens that in these patients, a very simple touch may exacerbate pain or may trigger the pain. Is that right? Even some of these patients have a special trigger point. It may be few millimeters. When they touch there, severe pain come. They will not let anyone to touch there. Right? We can say there can be trigger. Yes? Trigger zones. Right? Now, classically, tactile allodynia. What may trigger the pain? Right? Tactile, yes. Simple face washing. Touching of the face. Touching. Face washing. For men, face shaving may precipitate the attack. For women, yes, face makeup. Sometimes, unfortunately, teeth brushing may precipitate the pain. Or, very unfortunately, I feel so sorry, even kissing can precipitate the pain. Kissing can. Even the patient cannot kiss their grandchild. Usually this pain is more common, trigeminal neuralgia, in elderly patients, right? I should not forget to mention that about the 4 to 8 cases, the incidence of trigeminal neuralgia is 4 to 8 cases per 100,000 population per year, right? And mostly this is seen in elderly patients, 50 and plus patient, 50 year and plus, in middle aged and elderly. Again remember, younger patient, think of multiple sclerosis, and it's more common in female, right? Women. Am I clear? So this can be triggered, either it comes spontaneously and paroxysms of this pain, or it may be precipitated by some movement like smiling or eating, chewing, swallowing, or it may be precipitated by some tactile stimulus like touching the face or face washing, shaving, makeup, brushing or kissing. Sometimes it's so sensitive, even just a draft of air may touch and precipitate the pain. Patient don't know where to take their face. It's very painful, right? And all these things sometimes drastically reduce the quality of life in the patient. Am I clear? And then severity. Severity, of course, it's very severe, right? It is very severe. But in the time period, I want to mention something, right? That this pain acts as I told you, it comes as paroxysms, or it comes as a single attack. But actually, it may come as a single jab, or it may be repeated attacks in a very short time. Cluster of attacks, but not cluster headache. Cluster headache is a different disease. I'm saying cluster of attacks of trigeminal neuralgic pain. So these clusters of attack, one attack or multiple attacks may come into rapid succession. Is that right? And these attacks may come for some weeks. Yes, you see, there's multiple attacks come. Then for a few days or weeks, multiple attacks come, and then there may be a time of remission, right? Patient may have peaceful time for a few months or even years, but almost inevitably again return. But on return, attacks become more frequent and remission time become less. And then again, after a few months or years, again attack come. Now attack lasts longer and remission become less. Is that clear? Pain is so severe. S stands for severe. The pain is so severe, we use the word excruciating pain. It's so severe pain that patient always remember his first attack. Patient doesn't say, I just see. Patient will exactly remember when the first attack occurred, what patient was doing, and what was the moment and what was the situation. It's so severe pain. Is that right? So these are the basic clinical manifestation of this disease, right? That in classical trigeminal neuralgia, now I'm going to tell you about classical trigeminal neuralgia. In typical trigeminal neuralgia, right, what really happens, there's unilateral facial pain, which is more in the mandibular area, less in the maxillary area, and least in ophthalmic area. It may be felt in gums, cheek, lips, or chin. It comes as a sudden attack or paroxysm or episodic pain, which feels like electric shock or lancinating, cutting, or stabbing pain, right? Some patient makes mention that they feel as if pain radiates from the angle of mouth to the ear or to the eye, or rarely to the nostril. Usually pain is so severe patient winces face, and that is why it is also called Tic Douloureus. Thank God this pains last only for few seconds to 1 to 2 minutes. It's not a long-term pain, and it can be precipitated as spontaneously, or it may be precipitated or triggered by some movement allodynia like smiling, eating, chewing, or tactile trigger zones may be there on the face, trigger zone on the lips, on the gums, and these trigger zone, tactile allodynia, may make the patient a lot of problems, like pain may be precipitated by touching or facial washing or shaving or makeup or teeth brushing, or sometimes even a draft of air, right? That can precipitate the pain, and usually pain is of course very severe. Is that right? Now one more thing which I want to mention, that this pain may be classical, a typical classical case of trigeminal neuralgia, or sometimes neuralgia come as a symptom of some other disease, and we will go to that now, right? That neuralgic pain may come as a symptom of other disease. Let's start about type of trigeminal neuralgia and underlying mechanisms. I mean, we'll talk about pathophysiology of the disease, right? We'll talk about pathophysiology of the disease, why this pain occurs, why patient have trigeminal neuralgia, what is the underlying cause, what is the underlying mechanism, right? Now, as far as when we are going to talk about the underlying mechanism of the disease, and especially investigation or management, we divide the trigeminal neuralgia clearly into two groups. Into two groups of trigeminal neuralgia. Number one, trigeminal neuralgia, which is a classical case, which is classical case, typical case. Trigeminal neuralgia or classical trigeminal neuralgia. We can say the patient which have classical trigeminal neuralgia, I will explain how it is different from, and there are other patients which we say they have symptomatic trigeminal neuralgia. Now what is the difference in them? There's a lot of difference, and a good doctor should be able to differentiate them. Let me tell you, in classical trigeminal neuralgia, usually clinically what happens in patient with a classical trigeminal neuralgia, that all the features of pain which I mentioned, they are there, but there are no sensory deficit there, no associated symptoms like 7th or 8th nerve damage, and there is no numbness, facial numbness in between the attack, right? Why? Let me explain. Let's suppose here is your beautiful brain stem. Okay, I will make it black. Here is your brainstem, and this is pons, and here is medulla, right? And here comes out your trigeminal nerve from the mid-pontine area. This is, I think I should make a frontal view, that will be better explanation, right? This is midbrain, and here is the pons, and here is medulla, right? And here are trigeminal nerve. Here is the right trigeminal nerve, and there will be the, yes, it will be right, and there will be left. So this is one trigeminal nerve which is coming out from here, and this is other trigeminal nerve which is going out from there, right? And of course trigeminal nerves will, where they are approaching? Yes, ganglion. You know, they are going to have a painful situation. Look at their expression, right? And from here you know that, what is this division? Ophthalmic division. And there is, yes, maxillary division. Very good. And here it is mandibular division. And of course there is motor root also, but I'm not drawing the motor root here. Here again also there is ophthalmic division, and there is maxillary divisions, and there is mandibular division, right? Now what really happens? These are now nerve fibers. These are the nerve fibers which are in the sensory root. These are the nerve fibers which are present in the sensory root. Now, why this disease occur? First I will tell you in classical cases, what is the underlying problem? Why they have a pain like this, which is sudden, severe, episodic, paroxysmal, lancinating? What's happening there? Actually, in these classical cases, there is a problem that there is some blood vessel which is rubbing or pressing the nerve root. Now here I must mention that there are vertebral arteries here. Yes, what are these arteries? Vertebral arteries. And vertebral arteries at the pontomedullary junction, they unite together and they convert into basilar artery. This is vertebral artery, they unite together and they convert into what? Basilar artery. What is this? This is vertebral artery, right? This is also vertebral arteries, right? And what are these artery? Basilar artery. And you know, basilar artery goes in pontine, and here it divides it into its final branches. And these final branches are, can anyone tell me? Posterior cerebral arteries, right? What are these? Posterior cerebral artery, which are going posteriorly, right? Posterior cerebral arteries. Now, what really happens in these patients? Actually, there is an artery here which is called superior cerebellar artery. Here is cerebellum. What is here? Cerebellum. Okay, this is cerebellum. Now, here is an artery which is supposed to go out, and it should go at the top of cerebellum. What is this? Superior cerebral arteries. This is superior cerebral. Sorry, this is posterior cerebral. This is superior cerebellar, because this is going to the back of the cerebrum, right? This is going at the top of cerebellum. So superior, yes, cerebellar artery, right? Superior cerebellar artery. Sometimes what happens, now this here is the understanding, this artery may loop over the nerve while en route, and it may compress the trigeminal nerve root, right? It may compress the trigeminal nerve root. This compression, vascular compression, may trigger the pain of trigeminal neuralgia. The pain is really not coming from here. Patients feel pain is coming from here. It is just like that. Here is your ulnar nerve. If someone hits your ulnar nerve, you feel pain in all this area. If someone irritates ulnar nerve, you feel electric shock like pain here. Because actually you stimulated the pain, stimulated the ulnar nerve here, and action potential started from here and went to the central nervous system. In the same way, this artery is rubbing against the sensory root at near the entry zone, and there it irritates what? Sensory fibers. And sensory fibers which were taking information, sensations from the face, they were taking the sensations from the face, On the way they were taking sensation to the central nervous system. When it was irritated here, action potential were produced locally here. Pathological action potential, ectopic action potentials, they were produced by this pathology, and this action potential are generated here, and from here they go to the central nervous system and patient perceives a severe pain. You understand what is the underlying mechanism?
Yes.
Now, it may be superior cerebral artery, or it may be an anomalous tortuous vein. Sometimes there is some vein nearby, right? There are many veins here, and some vein may be rubbing here. So we can say that classical attack, yes, now you come here, the classical case of trigeminal neuralgia, it may be due to some vessel, artery. Most common artery involved is superior cerebellar artery, or it may be a vein, right? A tortuous vein, right? It may be rubbing on that, right? And irritating these neuronal fibers. To be more accurately, they actually demyelinate the heavily myelinated fibers. I will go into detail, but before I go to the detail, I want to come here. Okay, I go detail first here. Let me draw these fibers here, right? Now, I draw the nerve, that these are the nerve fibers. They are taking information to, here they are taking information to central nervous system, right? And if these fibers are taking information, now, some fibers are very fast fiber. From the face they are taking sensations. They are called A alpha fiber. They are heavily myelinated. Then there are A beta fibers. They are slightly less myelinated. Then there are A delta fiber, which are least myelinated, right? Now, A delta fiber take pain sensation. They take pain sensation, A delta fibers, right? And then there are least myelinated fibers, and these fibers are C fiber, and these are also or almost no myelinated. These fibers also take the slow pain. A delta fiber take fast pain. For example, when there is pin prick pain, A delta will take. But if there is some burning pain, this will be C fibers take. And A alpha take proprioceptive fibers in sensations, and A beta take fine touch, tactile, 2-point discrimination fibers. You are understanding? Now, these fibers are heavily myelinated. These fibers are heavily myelinated. It means they have lot of myelin cover on them, right? They are heavily myelinated. It means they have lot of insulation on it. As you know, in common life you see there's a copper wire and there's a lot of rubber on it. Rubber is like an insulation on the wire, so that wires don't short circuit.
Yes.
Is that right? These neurons are very, very sensitive, and they are provided with a lot of insulation. This insulation, number one, prevents the short circuiting. Okay, I will make this red so you don't confuse it. The pain pathways, A, delta and C fibers, they are here, right? These fibers are all present inside here. Now, these are heavily myelinated fibers, and myelination increases their conduction velocity, and they are very, very sensitive. Now, here is also heavily myelinated fibers. You see? Now, what really happens in this disease? This is also heavy myelinated. Now, what really happens when there is compressive blood vessel? Let's suppose this blood vessel. When this blood vessel is repeatedly rubbing against this area, it will damage the myelin sheath. So it's just like copper wires which have lost their rubber cover. Chances of short circuit. Very good. So what really happens, that due to this vascular compression and slight rubbing here, actually myelin sheath is lost here. Demyelination occurs. Myelin is damaged here, right? And this demyelinated area of the fast conducting fibers which are taking proprioception, sensation for the movement, and fine touch sensation, they become demyelinated at multiple points, and when they become demyelinated, what will happen? They will become hyperexcitable. They will become injured. They are diseased, they are injured, they become hyper abnormally more excitable. Right? And sometimes by simple rubbing of this vessel, it may activate action potentials here, signals. Now, because they are poorly myelinated here, short circuit will occur and these fibers will spill their action potential electrically coupled with pain pathways. Pain fibers are also lying nearby, and here are fast conducting fibers. When these fast conducting fibers are demyelinated and they become hyperexcitable, they produce automatic spontaneous action potentials. These action potentials, yes, may become electrically coupled with pain fibers, and pain fibers take a very rapid succession of train of action potential, producing a classical pain of trigeminal neuralgia. Now you understand why this pain comes? Right? That is why the treatment of this classical situation, either you stabilize the nerves pharmacologically. Later on I will tell you, we use the drugs which actually reduce the activity of sodium channel in these nerves, so that chances of excessive production of action potential is reduced. Right? Or in the surgical management, you can do one thing, lift this, what is this? Abnormal vessel away from this area, or between the vessel and between the trigeminal nerve root, you put a little cushion, Dacron cushion, or by radio frequency ablation or by gamma knifing. I will discuss these things in detail in later lecture. You damage these neuronal pathway so that pain is not triggered again and again. But this explanation also beautifully explains one more thing, that why a stimulus which is not painful produces pain in this patient. A simple touch which was carried here, these action potential from here jump to the pain fibers and produce severe pain. Or simple movement of lip or tongue, or simple movement of facial muscles, right? Smiling, that movement sensations were going through proprioceptive fibers, and this area short circuit occur and pain fibers are inappropriately, unduly activated. Or someone lightly touch here, or putting makeup, a little draft of air, right? A simple kissing here, may these sensations, kissing sensations go to your central nervous system. Sometimes they have emotional component. So simple kissing here may start the train of action potential from here, but here the action potential system electrically short circuit, electrically coupled with the pain, and severe pain is precipitated. Now you understand? Yes. But one thing very important. Usually this vascular anomaly or vascular pressure, even though demyelinates some fibers, but does not completely destroys the fibers. Because it does not completely destroys the fibers, right, there is no sensory loss. In classical case, what I told, that what is there? No sensory loss. No sensory loss. Right? Secondly, in this such classical case, there is another thing, that usually if there is fiber destruction, if there is some pathology or which is destroying the fibers, right, then not only patient has episodic pain, but in between the two episodes of pain, facial area may be numb. There will be abnormal sensations. For example, a person get a very severe attack, right, and after the attack he is having some area of the face which is numb or heavy, and then later on he develop another attack. Now in between the two attacks there may be facial numbness. This occurs when truly some pathology, some nasty underlying cause is destroying the fibers, which I will discuss here. These usually demyelinate the fibers. They remove the rubber, but don't cut the copper. But if there is some more dangerous causes, which I will explain here, they not only remove the rubber, not only demyelinate the fibers, but also cut the coppers, right? Axons are also damaged. Then their area of sensory losses will be there, and in between the attack, in between the two attack, facial numbness will be there, and that is called interictal numbness. Ictus means attack. So these patients do not have, they do not have interictal numbness, facial numbness. Is that right? Another thing, if artery is pressing here, usually does not get so big that it does not press nearby. There are, seventh nerve here. What is this? Seventh nerve here, and here is eighth cranial nerve. Right? Usually this does not get so large that it compresses seventh and eighth cranial nerve. So it means in these patients there are no associated symptoms like damage to the seventh nerve, which may end up into facial paralysis, or damage to the eighth nerve, which may end up into hearing loss or tinnitus or vertigo. You understand it? So they are not serious associated symptoms. No serious associated symptoms like seventh nerve palsy or eighth nerve complication like deafness or tinnitus or vertigo or other complications. Am I clear? Yes. But there is another category of patient with trigeminal neuralgia. There is another category of patient with trigeminal neuralgia which have more dangerous underlying causes. Yes. Right? Because this is less dangerous. Classical case is less dangerous. Blood vessel is rubbing here, but it is not going to kill the patient. Of course, it causes very severe pain. It reduces the quality of life. Patient is always having fear that disease may not come again. But still, definitely does not kill the patient. But sometimes there is some more dangerous cause here, which is damaging nerve root or the ganglion, right? And those dangerous causes, what could they be? I'm drawing them very dangerous, right? These very dangerous causes, yes. What are these dangerous causes? Yes, I will tell you. If there is a mass lesion here, in some patient, trigeminal neuralgic pain come, but there is a mass there, not simple blood vessel. There is a bigger mass. Maybe one blood vessel has a part which has ballooned out. Not only simply tortuous vessel, but a part of some blood vessel part which is near this area, and that is ballooned out. We call it aneurysm. So there may be arterial aneurysm, right? Or there may be some type of tumors, cancers. There may be here neurofibroma, or there may be acoustic schwannoma. Very good. SCH schwannoma. These are tumors. Or there may be meningioma. If there are such dangerous things there, aneurysm or neurofibroma, or there is acoustic schwannoma or meningioma, right? If it is compressing the nerve, of course, these will compress, and of course they will produce lancinating pain, episodes of pain, which is trigeminal neuralgia. But not only they will produce this, they will also destroy, they will do deeper destruction of the trigeminal nerve root. And if there is deeper destruction, then you will develop these things. There may be sensory loss. There may be sensory loss on face, right? If there are dangerous causes. Or there may be interictal facial numbness. Facial numbness occur when some process is destroying the nerve. When this mass rub the nerve, classical like attack come. Classical like attack come, but once the attack is over, because part of a nerve is being damaged, facial numbness or sensory loss will be there, sensory deficit will be there, and then this mass may become very big. It may damage the 8th nerve which is coming out from here, or it may damage the 7th nerve, right? So there may be serious associated symptoms also, serious associated symptoms also. Due to this reason, we say when patient with trigeminal neuralgia, in between the attack, he has sensory losses, or he has facial numbness, or he has other dangerous associated symptoms, you should think this trigeminal neuralgia is a symptom of some other dangerous pathology. This trigeminal neuralgia is just a symptom of an underlying dangerous thing, not just a simple blood vessel. This type of trigeminal neuralgia, we say symptomatic trigeminal neuralgia. So what do you learn from it? When a patient with trigeminal neuralgia comes, usually the diagnosis of trigeminal neuralgia is easy. It's a very, very classical and typical pain. What is a difference in good and bad doctor? A good doctor will try to evaluate that is it a classical case or is it a symptomatic case? Because there is a saying, in a patient with trigeminal neuralgia, if facial numbness appear, if sensory deficits appear, if 7th, 8th nerve or other worrisome associations occur, doctor should get worried, and you need to investigate the patient very thoroughly. Am I clear?
Yes.
Right. Then, we should not forget multiple sclerosis. Multiple sclerosis, or we also call it what? MS. In patients with multiple sclerosis, as we will discuss in another lecture, that in multiple sclerosis, there is immune mediated damage to the central myelin system. You know, in central nervous system, myelin sheath, the insulations are produced by oligodendrocyte. Actually, in multiple sclerosis, there is T cell mediated, T lymphocyte mediated damage to the oligodendrocyte made myelination in central pathways, and result into what? Different plaques, because when demyelination occur, and those demyelinating fibers, when immune mediated damage to central fibers occur and they get demyelinated, there is reactive gliosis, and that reactive gliosis can be seen by MRI as a plaque, PL, right, as a plaque on MRI, radiodense plaque. So if the patient in multiple sclerosis may have multiple plaques at different time and at different times in the same patient, at different times and at different locations in central nervous system, these demyelinating plaques, right, because they are multiple and they are disseminated at time and site. For example, sometime in patient, this demyelinating plaque may be optic nerve, then it may be in ascending fibers like medial lemniscus, then this plaque may be in trigeminal system, right, demyelinating. So because this occur at multiple points and those areas, demyelinating area, look hardened or sclerosed, so we say multiple sclerosis. So what really happens in patient with multiple sclerosis, sometimes there is demyelination, immune mediated damage to bilaterally, what is this? Trigeminal nerve root entry zone. Because in previous lecture when I told you anatomy of the trigeminal nerve, I told you something very strange about trigeminal, that trigeminal nerve about 7 millimeter from its exit, it is myelinated by, axons are myelinated by oligodendrocytes, not by the Schwann cells. Because normally peripheral nerves are myelinated by the Schwann cells and central nervous system fibers are myelinated by oligodendrocyte. Is that right? But at the sensory root entry zone, about 7 millimeter area is also myelinated by oligodendrocyte. So it means here the myelination is having the characteristics of central myelination. So those diseases which produce demyelination of central nervous system myelin may affect these roots of trigeminal nerve. And one of the diseases is multiple sclerosis. So multiple sclerosis can also produce trigeminal neuralgia, usually in younger patients, because this demyelinating autoimmune disease is more common in younger patients, right? And usually this disease may attack bilaterally. Am I clear? Any question? Before I close the pathophysiology, I must mention the classical cases are more seen in 50 plus patient. Why in older age? These vessels more compress the nerve. The reason is very simple. With age, our brain shows a little bit sagging. It settles down a little bit. So vessel may start rubbing more, right? So why it is classical cases especially are in elderly? Number one reason is that there is age related brain sagging. Age related brain sagging. Number two, with aging, blood vessels become thickened and more tortuous. So as patient ages, if already blood vessel is very near to this sensory root, when brain little bit sag down and vessel become more hardened and tortuous, the chances of compressing the root of trigeminal nerve are more. That is why this disease is more common after 50 plus in middle-aged people and elderly patient. Is that right? So let's have a break, then we will continue with differential diagnosis and other aspects of disease. But before the break, I will make it a few words about investigation. We don't do a lot of investigations in this patient. If patient is a very classical case, I mean there's no sensory losses associated, no interictal numbness, facial numbness, no serious associated symptoms. If patient is classical, usually we don't need any investigation. We don't need MRI. If it's a clear-cut classical case, and as I will mention later on, we just give, try the drug, first-line drug is carbamazepine. But if you are planning for surgery and you want to remove the blood vessels, lift it off the nerve, that surgery is called microvascular decompression surgery, right? So microvascular decompression, when you are planning for that, of course then you need to do MRI, right? And MRI so that you know exactly the relationship of the guilty vessel and the innocent suffering nerve. You must know the exact relationship before you open the skull of the person, right, and approach there. You must know what is the exact illegitimate relationship between the guilty vessel and the innocent suffering nerve, right? Then MRI become mandatory even in a patient with classical cases. And of course, if patient has symptomatic trigeminal neuralgia, if you suspect patient has symptomatic trigeminal neuralgia, then you are thinking about some very dangerous mass lesion inside. Of course, you must do CT scan or MRI. Neuroimaging is mandatory. Moreover, in patient who is suffering from, if you suspect multiple sclerosis, right, then you have to do the test for multiple sclerosis. As I will mention in lecture related to multiple sclerosis, that one of the tests is evoked potential, which may be delayed evoked potential, or other test is in CSF, you check the protein electrophoresis. In patients with multiple sclerosis, there are oligoclonal IgG band in electrophoresis of the CSF in multiple sclerosis, but they are not specific for multiple sclerosis. They are seen in some other inflammatory conditions of the central nervous system as well. But that will be discussed in detail in lecture with multiple sclerosis. Another disease which may mimic the facial pain here, that is temporal arteritis, which I will discuss into detail in its differential diagnosis. But to rule out the temporal arteritis, we must do ESR, because patient with the temporal arteritis, ESR level is high. Alright, so let's have a break.